today. We have with us Dr. Jonathan Prowski. He is the Chief Naturopathic Medical Officer at the Canadian College of Naturopathic Medicine in Toronto, Ontario. His primary responsibility is making sure that the safe and effective naturopathic medical care to patients is provided, and the medical training to the students in their ND program is top-notch. His clinical practice and has focused on the evaluation and management of mental health problems, where he spent almost 20 years advocating for patients that wish to receive complementary and alternative means to help their mental health struggles. And so with that, I'm going to turn over the day to Dr. Prowski, and I thank you so very much for joining us this morning, this afternoon, where you are in your time zone. Thank you.
Well, thank you, and I'd like to say hi to everybody who's watching right now, and I'd also like to say thank you to the AANMC for this opportunity. As the title says, we're going to talk about suicide prevention, and really my hope is that you'll get a sense of the phenomenology of suicide and the importance of discussing it with patients who are thinking about suicide in some manner or another. Now, the title's a little bit of a misnomer. It says suicide prevention. You have to realize that there are no treatments that can stop people literally from dying by suicide unless, of course, we had them hospitalized where they were kept safe. Otherwise, it's an incredible thing to prevent, but certainly there's ways we can manage these very distressed patients, and there's a lot of things that we can do to really help them. So let's kind of move on, and we're going to get really into the nitty-gritty of suicide, but I'm also supposed to talk a little bit about my story and how I've got to where I am at this moment in time. So my undergrad degree was at the University of Toronto. I did a honors degree in physical and health education, and it was really there that I became really interested in health and natural ways of bettering one's physical and mental ability. What was interesting is at that time, and this is going back many years, over 2 decades ago, I wasn't really aware or familiar with naturopathic medicine, but I happened to be riding the subway one day from the University of Toronto, and there was an actual sign in the subway that said, the Ontario College of Naturopathic Medicine. And I looked at that sign, and I had no idea what it was about, but something compelled me to learn more. And from that day forward, literally, while I was an undergrad, I interviewed several naturopathic doctors. I actually wrote a paper on a naturopathic doctor, and it certainly led me to apply to Bastyr University and other naturopathic medical schools, and then I accepted Bastyr University's offer, which I thought was fantastic. I was thrilled to go to Bastyr, and I was thrilled to begin my journey into naturopathic medicine. Now, when I graduated Bastyr in 1998, I did a 1-year residency sponsored through National from Portland, Oregon, and my residency was in family practice in Marysville, Washington. And during that residency, I started focusing a lot of my work on neurological diseases and mental health. And it really became a passion of mine ever since. And literally, to this day, I've spent now over 20 years working with patients who have mental health issues. And it's not that I believe I can cure them. I don't work from a paradigm of cure. I work from a paradigm of help and hope and management and offering whatever I can do to lessen the intensity of a patient's overwhelm. So I always think there's a lot we can do, and I think what's wonderful about our medicine is that we can integrate our treatments with mainstream treatments. We can also assist patients to find resources that they need. We really partner with our patients to better their lives, and that's what really has been an inspiration for me all these years. Now, in terms of extracurriculars in my life, I watch a ton of movies, probably too many. I love hockey. I love the Toronto Maple Leafs. We have a great team this year, so maybe we could actually win the cup this year, although it's been literally over 50 years since Toronto has won a Stanley Cup, which is mind-boggling. Anyways, let's hope that happens. But now let's get into this very serious topic, and my hope is that a lot of you will have questions, and I'll try to answer as many as I can as we proceed. So let's first look at some sobering statistics about suicide. And I'm not going to read you the slide. I'm just going to point your attention to where it says on average there are 123 suicides per day. So when you think about that, that's pretty unbelievable. We often think of suicide as something that's fairly rare. From my vantage point, I should say, I think of it as a very, very common experience, and regrettably so. As much as it is rare when we compare it to other problems of society, 123 suicides a day in the United States, in my mind, is not rare at all. And we ought to really look at it as something with our intensity and our focus and with whatever we can do to hopefully help these very distressed patients, because one death is too many as far as I'm concerned. And to me, it's a very devastating thing because it impacts so many. When you think about suicide, not only does the person end their life, but that person and his or her connections to so many others are stopped at that point. And of course, all the care providers involved in that person's care are impacted, and it goes on and on. So we have to think. It's just like there are so many neural connections in our brain. There's so many connections that we all have. Even if we have a small social network, we still have connections to people. So when someone dies like that, it's so awful and so devastating that I look at suicide as something very serious and something that we have to put a tremendous amount of resources toward. Now, in understanding suicide, I think what's important is to get a glimpse of the suicide phenomenology. And when we talk about phenomenology, we're talking about what might be the experience of somebody who's going through such distress and such overwhelm that they're thinking that suicide seems like a good idea. And I think if you can begin to understand the phenomenology of suicide, then it helps you to better relate to people who might be thinking about it, might be having suicidal ideation. They may even be thinking about how they want to end their life, etc., etc. So I always tell my interns and students that before you can really adequately help somebody, you have to know a little bit about what their life experience is like and what their worldview might be like and what their suffering might be like. And if you can understand bits of those components, then you're going to be better able to connect with them. You'll have a better relationship with them, and you'll be able to perhaps provide them the needed assistance, which is the most important, of course. So psychache is a term that was developed by Dr. Schneidman. It's been around for several decades, and it really, in my mind, encompasses a lot of the overwhelm that the suicide patient is sort of mired in. And we talk about psychache, we're talking about this intolerable, this unremitting psychological and emotional pain that nothing seems to be able to address. So because of this unremitting, overwhelming psychache, these patients are contemplating that maybe their death makes a lot of sense. Maybe ending their life makes a lot of sense because of how overwhelming their pain is. Another construct that we think about when we're trying to understand the phenomenology of suicide is hopelessness. And this really was well studied by the great cognitive behavioral therapist and founder, Aaron T. Beck. And he really did a lot of the work on hopelessness. And as you can see, it's actually more of an important mediator of suicide risk than depression. And it does better predict suicide intent compared to depression. So what we want to do is we always want to ask our patients if they're feeling hopeless and to get a sense of how hopeless they might be. Because as you can see here, it really is something that mediates suicide risk much more than depression. And we all know what it feels like to be hopeless, but to imagine now thinking about what that could be like every day from the moment you wake up to the moment you go to bed, and that would just cover and shroud your whole life and make you so dejected, and you'd feel like a failure as a person just because regrettably that hopelessness would be so large. So to me it's certainly something to think about, and you would always want to ask these kind of questions to your patients. For instance, do you feel hopeless? And to have a conversation about that. Another construct that is really important is one called emptiness. And again, we all know what the experience of emptiness is like because we're human, and we know what it's like to be bored, to feel apathetic, to be alienated. But imagine, again, just like hopelessness, imagine if that was just something that was so pervasive in your life that it was inescapable. You felt this constant and unremitting sense of emptiness no matter what you did. And that is a pretty harrowing thing to think about because emptiness is not a fun emotion. I felt empty at times in my life, and I'm sure many of you have at times. But to feel it constantly and chronically, and to have that then mixed in with the idea that maybe your death makes a lot of sense, you can imagine once again that that could be a very overwhelming experience. Now, when we look at emptiness, we know several things that are rather interesting about it. One is that it is related to non-suicidal self-injury. So these are people who like to say self-harm. They're not trying to kill themselves, but they're trying to harm themselves. So there's a relationship then between emptiness and that type of behavior. There's also a relationship between parasuicide and suicide attempts and emptiness. So when we're talking about parasuicide, what we're talking about are individuals who may cut their wrists, but not deep enough to kill themselves, but definitely deep enough to cause a problem. So that's a parasuicide. They're not trying to end their life, but they're definitely trying to inflict a fairly significant amount of pain, physical pain, to remedy whatever it is that they're going through. And of course, emptiness, as you can see, is also related to suicide attempts as well. What's interesting when you look at the literature on suicide phenomenology is there are some reports about emptiness, and one I was able to find in 2008 where it looked at the content of suicide letters. And when they looked at that content, they found there was a lot of emptiness that was expressed and displayed in these letters, and thus the authors of that paper said or stated that there seems to be a relationship between the feeling of emptiness and then suicide itself. So once again, if we were just to recap a little bit, we talked about psychache to begin with, then we talked about hopelessness, and now we're getting into emptiness. And you can ask all sorts of questions to people once you have established a good relationship with them, because the worst thing you could do when you're working with somebody who has such distress that they're contemplating their own death is to not talk and not to have a reasonable interaction with them. You want to make sure it's as meaningful as possible. And in doing so, all you have to do is ask all sorts of questions. And you could even ask them straight by saying, are you feeling empty inside? And can you tell me what that experience is like? And I'd like to understand you better. Because the more we can understand another human being who's in front of us, the better we'll be able to assist them. Another construct that I think is rather harrowing and upsetting is when people lose a sense of themselves. So imagine you're looking in the mirror, and when you're looking in the mirror, you don't see yourself anymore. You see someone entirely different. You've lost any sense of who you are, of your place in the world. And of course, if you lose your sense of self, any future for yourself has also been lost, because if you're lost in the present, you're also lost in your future. And there's definitely a relationship between the phenomenology of suicide and individuals who lose that sense of themselves. And I think about this a lot. I mean, what would it mean if you woke up one morning and over the course of the day you slowly felt more and more eroded as a person, that by the end of the day you kind of looked at yourself and didn't recognize who you were anymore? And maybe you could recover because that's just one day, but imagine again, like I've said before, imagine if that keeps going on and on and on, and eventually it's going to take its toll. Eventually you're going to feel like you have nothing. So this is a really important thing to sort of think about, this loss of self and its importance in those who are thinking about suicide. Escape from self is another suicide construct. It makes a lot of sense. If your life is so horrible and you're thinking about dying by suicide, or you're mired in suicidal ideations, then of course wanting to escape from your current circumstances and from who you are makes a lot of sense. I mean, that makes rational sense. I mean, think about it. We all numb ourselves to some degree when we're in some kind of pain. We will numb ourselves just to dampen or to de-intensify whatever overwhelm we go through at times. So it makes a lot of sense for the person who's mired in suicidal ideations, who's contemplating suicide, to want to escape from who they are, because they're not quite happy with who they are. They're very devastated by who they are. So they just want to get as far away from themselves as is possible. And in doing so, suicide again makes a lot of sense. A construct that I think is rather fascinating, and I'll tell you a little bit why a little bit later, is the sense of thwarted belonging. Now, in and of itself, it has some association to suicidal behavior. And really, when you think of thwarted belonging, you can imagine it in a massive way. Imagine you were going somewhere, a social occasion, and no one was friendly to you, no one said hi, no one even acknowledged you when you came to the door and you entered the wherever you are, and you were literally ignored, and you didn't feel like you belonged to anything, and you felt so alone and isolated, and you lacked any kind of connection to people. Again, that's what we call thwarted belonging. It's a perceived or actual experience where you lack social ties, you have strong feelings of loneliness, and you just don't have a sense of belonging. And that's not uncommon. When you talk to enough patients who are thinking about suicide, it's amazing how many of them actually feel that they don't belong, they don't have a group that they're connected to, and they just don't have that bond to many people in their life. Another construct that is extremely important, just like what we just talked about, that sense of not belonging, is this also sense of not of being a burden onto people. So when you talk to people who are in mental distress, not even people who are suicidal, a lot of patients who are in mental distress will say to you, I just don't feel like I'm good for my family, my parents, my loved one, my spouse, etc., because I think I'm just a burden to them. I feel so bad because I'm just making their life miserable. Now imagine that same person who is now feeling even more extreme in his or her experiences, where they feel they're such a burden, and as a result of feeling like such a burden, they just think that their death would help those around them because they wouldn't be burdened by them anymore. So these are patients who are thinking that they're such a burden that killing themselves makes a lot of sense, because at least it would help those people that are in their life from feeling so burdened by their mental, you know, problems and struggles and so on and so forth. So, this is again a very important construct, and I talked to a lot of patients, and a lot of them do express this. And some of those patients who are suicidal and thinking about suicide express this quite a bit. And you can see when you look at the slide, there's some things about it that are rather harrowing. How it's predictive on some level to suicide lethality, and that's an important thing to remember when we proceed here. So what am I getting at? Well, there's a Dr. Joyner who's a researcher, an academician, and a clinical psychologist in the United States, and he is probably one of the leading authorities in the world on suicidology. He spent a large part of his life, in fact, a lot of his life, studying suicide because his own father died by suicide when he was, I believe, in his 20s. So Dr. Joyner had certainly a traumatic experience, and from that, he's devoted much of his life to try to help those who are suicidal and to help professionals to better recognize some of the very important things that we have to recognize when we're working with people who are suicidal. So he put together a theory called the Interpersonal Model, or theory of suicide, and in my mind, it's something that is tremendous and tremendously helpful as a clinician. So when you look at this screen here, it really looks at different constructs. Those who desire suicide. So these are patients who are seriously contemplating suicide. And when you have that perceived burdensomeness and you have that thwarted belongingness, then you have a mixture of these very important constructs that could increase one's ability to die by suicide. But then you look at that third construct there that we haven't talked about, that says those who are capable of suicide. And what Dr. Joyner is really talking about there is a sense of fearlessness. Because when people are likely to attempt suicide, what's regrettably fascinating about this whole subject is they're becoming more and more fearless. And it's not just their fearlessness that will push them over the edge. They have to also have those other constructs that I just mentioned, like perceived burdensomeness and a thwarted belongingness. So when people are fearless about their own death and they have those two other constructs, then we know they're at great risk of suicidal behavior and even dying by suicide. And some of the clinical features that Dr. Joyner has talked about when people become much more likely to die by suicide when they also have those other constructs is their blink reflex will be much more, I would say, diminished compared to me. For example, I know I'm doing some kind of a public talk right now, so my nervous system is mobilized to some degree, but I'm probably blinking maybe every 3 to 4 to 10 seconds. But when you're talking to somebody who's fearless and who is thinking about suicide and who has those constructs I just mentioned, what you'll notice is they really won't blink at all. Their blink reflex goes way, way down. And when I say down, I mean it's much more prolonged. So they're barely or hardly blinking. It's almost like they're getting themselves mobilized to finally end their life. And he has some wonderful presentations on YouTube, and I would recommend all of you to watch them because he really goes into his interpersonal theory in great detail. And he also talks about the sense of fearlessness and how it's a strong component or how it's strongly related to those that die by suicide. And one of the things he mentions, which I think is so important to think about, is people who have previous attempts. It's like they're practicing for the inevitable. So when we look at risk factors for suicide and we ask patients about if they've ever had an attempt, we have to take that incredibly seriously because it's like they're practicing, they're becoming more and more fearless. Even the person who self-harms and cuts and cuts and cuts, they're becoming more and more fearless. And then when you add in that fearlessness with those other constructs, then we are unfortunately seeing a person who's going to be at greater and greater risk of dying by suicide. So these are really important things to think about when you're working with anybody who's in a lot of distress and who's thinking about suicide. Now, other factors, or risk factors that Dr. Joyner talks about, which I think are worth getting into as well, is the idea that when someone dies by suicide, and this is sort of harrowing and it's also so sad, it makes me sort of sad to think about it, or very sad if you really think about it, that when people die by suicide, 70% of those people that died by suicide have told people of their plans before they died. So again, when you're working with a patient, you simply want to ask them a very direct question. Have you thought of an actual plan, a real mechanism by which you would take your own life? Have you really thought about how you would kill yourself? And you want to be really direct and ask people about if they do in fact have a plan. And because as I just said here, 70% of people that die by suicide have told people of their plans in advance. So again, it becomes a really important question to ask. Now, a lot of patients who are likely to become more suicidal are those that are highly agitated. If you have a patient and from visit to visit, he or she is becoming more and more agitated, that's something to really take note of, but also something to not let go. You want to be very clinically vigilant about your agitated patients, and you want to see what's going on with them because, again, it can be so extreme agitation at times that people may want to, unfortunately, take their own life. Insomnia is another one. We know how it feels to not sleep well, but for people who have chronic and persistent insomnia, as well as other risk factors, of course, that also can drive them to believe that suicide is a rational and good idea for themselves. So we really want to question and ask our patients about insomnia. Nightmares, you want to ask them what kind of dreams they're having. Are their nightmares very upsetting? Are they violent? Et cetera, et cetera. That's another risk factor apparently in people that may be at imminent risk for suicidal behavior. And marked social withdrawal. It's not uncommon for patients who are contemplating suicide, as we just talked about in the preceding slides, for them to feel that they don't belong, for them to feel empty and lack any social connection to people, for them to not have these good social networks that hopefully all of you have. So if you look at these other risk factors, these are also important, not to mention the interpersonal theory or model of suicide that I just spoke about, but also think about all of these risk factors when you're working with patients, because these particular ones have definitely a stronger role to play in any imminent risk of suicidal behavior. So what's the clinician's approach? Now, my talk is really about the phenomenology of suicide, and I'm not here to tell you that just from my talk alone you're now prepared to work with people who are suicidal. what you're really getting now is a glimpse of some of the feelings and overwhelm that these patients might be going through. But you'll need a lot more training, as we all do. And more training is always helpful, because when you're working with somebody who's in this kind of distress, it can be overwhelming. But I like this quote that I took from this particular paper. It says, as clinicians, we ought to take time and engage in a meaningful phenomenology of suicide by trying to understand the suicidal individual's intimate world. And that's what I said earlier. The best you can do when you're amidst somebody who's in this kind of distress is to really take them seriously, of course, but to really try to understand what's going on in their life, to show them empathy, to show them compassion, to try to make some sense over their overwhelm so that they can feel heard. And perhaps from that, you can find some resources and help that they desperately would need. Without getting a good understanding of what's going on with the patient, it's unlikely you're going to be able to really help them in a way that you could. So there's a reality here which is true. It's really difficult to know what goes on in the mind of someone who wants to die by suicide, but we have to try, as I said. And I've also said quite deliberately that we have to show genuine concern for their suffering. If we don't show them that level of empathy, and we're not taking them seriously, then we're not going to help. Or if we're so uncomfortable with their own distress that it's overwhelming us so that we avoid it, that's also not a good outcome. We ought to get help if that's how you're feeling. Just get supervision, call a friend, call a colleague, get a colleague involved. Like, if you're ever feeling that you're not broaching a topic that is really important because of your own discomfort, that's the time to make sure that doesn't get in the way of actually helping a patient in distress. So what do I do if someone presents to me and their ideation seems very active and they seem to be having some strong feelings and they also seem to be thinking about suicide in a very real way? I'll do a thorough risk assessment, and that isn't just 5 minutes. I may take a good 30 to 60 minutes to do that. And at the Canadian College of Naturopathic Medicine, we have a really, really robust suicide assessment approach that all the students and interns are trained on, so that we have a very streamlined approach when a patient presents with very marked suicidal ideation. And the idea is that we can't necessarily predict what's going to happen, but we at least can engage the patient. We can definitely consider how risky or how likely it is that they may act on their impulses. And then we can certainly do the right thing. Either we send them to hospital by calling 911 and having a mobile crisis intervention team to come to the school and to do their own assessment and to take the patient to the emergency room or nearest hospital. Or if it's not as concerning, we do safety planning. Now, safety planning, again, won't prevent suicide, but what it does is it helps the patient to know what tools and resources he or she can engage with if and when they're feeling overwhelmed. But all I can say is the clinician's approach should always involve a very streamlined and systematic approach to patients who are feeling overwhelmed by suicide, such that you have a good system in place to manage these very overwhelming situations that do happen. Now I'm going to go through a brief case study, and let me just look at the time here to see where I'm at. Okay, I'll wrap up pretty soon so that I can take questions. But this is a patient that we'll call Jordan. All the identifying details certainly have been removed. So, I knew Jordan for quite some time. I worked with Jordan. Let's say he's in his late 30s, and Jordan came to me with very severe depression, very severe anxiety. He had tried seriously to end his life maybe 10 years before I saw him, but thankfully it wasn't successful. And Jordan had also been on, I would say, if I recall, maybe 7 or 8 psychiatric medications. I didn't find that any provided any relief. So I thought I had a good relationship with Jordan, and we worked well together over several months, and then I didn't see Jordan, and then he came back into my practice, and we worked together for maybe about 7 or 8 months. And in the last few months of working together, what I noticed with Jordan is that he was getting more and more anxious from visit to visit. He was expressing more hopelessness, and he was also more and more disconnected from people in his life, and he was also feeling like a burden to people in his life. And certainly I would ask and check in with Jordan about suicide, and certainly I did whatever I could to help. But regrettably, Jordan did take his own life at some point. I hadn't heard from him for a few months, and then for whatever reason, I just decided to Google his name, and all of a sudden I see that he had gone missing, and then a few days later they found his body. And it was probably one of the most devastating things to ever happen to me as a doctor. And no doctor wants to go through any experience where he or she loses a patient by suicide. But, in a sense, Jordan didn't die in vain, because the work with Jordan certainly inspired me to become better at being a doctor and better at managing patients. So from Jordan's death, I became much more, I would say, conversant in the suicide literature. And I worked diligently to create a much better process here at the school to streamline patients who are at risk, and to make sure that we have better mechanisms in place to help these patients. And I check in with patients much more often now as a result of Jordan's death. I make sure that we do a lot of safety planning, because that, to me, is a very important part of helping people. Safety planning just goes through symptoms that patients might be having that are leading them to believe suicide's a good option. It also helps them to know what resources they ought to engage with if they're feeling overwhelmed, and what people they should engage with when they're feeling overwhelmed. And really, to create proper safety planning, it takes a while, but you have to really sort that out with the patient. And then they leave your office with a whole sheet that has everything you've talked about under the sort of heading of safety planning. So it's incredibly important. So, well, Jordan's death was one of the probably most devastating experiences I've ever had as a doctor in practice, and I certainly had a breakdown of my own as a result. But it also helped me to become better, and it helped me to put better systems in place so that we can do a better job should another Jordan come around again. What are potentially effective treatments? I'm not going to go into great detail, and there's a few things you ought to know. None of these treatments probably act fast enough. If you're working with someone who's becoming more acutely unwell and dysregulated, and you're thinking suicide is somewhat of a possibility for this person, then these treatments wouldn't work fast enough. These are treatments that you could give to anybody who is depressed, and the hope is that their psychoactive effects would lessen the overwhelm of that depression. But there's so much more that we'd have to do as doctors than just giving patients pills. We have to really engage them in what a better life looks like, what a better way forward is for that person, and how they can accomplish that. And that takes a while. You can't sort that out in one visit. But these are treatments that, in my mind, are evidence-informed. The evidence on them is good. They can be used for major depression. And when I say they, I'm talking about St. John's wort extract and S-adenosylmethionine, SAMe. There's actually data in randomized clinical trials showing that these agents can be effective for patients with major depressive disorder of severe severity. Lavender extract would not be indicated for someone who has severe depression, but certainly someone who has some sort of mild or moderate symptoms of depression with anxiety could benefit from lavender extract. It has probably a little bit of a faster onset of action than St. John's wort and SAMe, but all these treatments should have enough time to be built up in the person's system to have an effect. So the best treatment we can offer patients who are truly suicidal is a good assessment, and then safety planning, or going to the hospital depending on how severe their risk might be.